So back to the sequence, I prefer maxillary anterior, then mandibular anteriors, and then mandibular posteriors, and then maxillary posteriors. And the reason why I do this is for occlusal plane. Our definition of occlusal plane is ideally the retromolar height, either 1/2 to 2/3, drawn across to the maxillary incisal edge. So if you think about this, our occlusal plane will actually cross through the mandibular lowers because we want some degree of overbite, right? So if we want, let's say that 1 to 2 millimeters of overbite, there will be a intersection of the maxillary or the mandibular anteriors and our anticipated occlusal plane. Once we have the mandibular posterior set, then we can go for articulation and inclusion with our maxillary posteriors to our mandibular posteriors. Okay? Did Dr. Song go over the different types of occlusion that we want to go for? Okay. So you guys have heard of bilateral balanced occlusion. You guys know what bilateral means and what the balancing part means too, right? Perfect. So because of that, we actually don't have to worry about that until we get to the posteriors. The anteriors is more so phonetics and for aesthetics. With the anteriors, I've made a few slides on how to select teeth. And I think no one does this in clinic. I rarely see people, myself even included, because it takes a lot of time, to sit your patient down and ask them, what do you want and how are we going to come to this decision together? They don't know anything. The patients don't know the shades or molds and sizes. It's up to you to communicate to them and then kind of support their decision-making process. If they have a pre-existing prosthesis, it's good to keep them and bring them in and use them as a reference point. Another great resource is to ask them to bring in teeth if they previously had teeth. A lot of times the patients want to restore their dentition, not necessarily replace everything, but make it look like what it was previously. And it's almost impossible, but we try our best by taking as much data as we can with what they previously had. There are 3 main categories. So there's tooth shade or color, there's the size, and there's the shape. The easiest is size. So that is from the distal of one canine on the upper to the other distal of the canine. And you're going to use your TrueBite ruler, and you'll see when you zero it and then you swing it around, there should be a letter between B and L. And those correspond with your size. You can report this size as either a letter or in millimeters in length. Next is the color, the shade. This is a little bit more difficult, and with patients who have lost teeth, their tendency is to go for something that is extremely white. And it's almost like chiclets. It's just blackout white and as white as they want it. And they think it's aesthetic. So sometimes I try to encourage them to think about a more natural tooth color rather than a whiter tooth color. And we have shade matching palettes. I think we use Portrait and also the Vita. So it's like A, B, C, and D. You guys know the difference between A, B, C, and D? Roughly? So it's the hue, right, of it. So A is more yellowish, reddish. D is reddish, grayish. C and D are generally for the elderly populations, more geriatric, because their hue color is tending towards gray. And as people age, the dentin gets more sclerotic and less innervated, so it changes slightly darker. That's the idea of A, B, C, and D. 1, 2, 3, and 4 are the chroma. So it's the value of it. So 1 is actually lighter than 2, which is lighter than 3. Okay? Okay. The last one is tooth shape, and I think for me this is actually the least concerning for me. This is purely up to the patient. There have been studies that say the tooth shape correspond with facial shape, but upside down. I don't know how real that is. It sounds like fake science, but it has been cited in some places, particularly in this textbook, which is Zarg 2018, I think. Next is, this slide is a nice slide just to read over and kind of have a general understanding on how to guide our patients to the correct teeth shape, size, and goal. For the shade and for the size. So once you've selected your teeth, you should document this in your notes. So if ever a patient requires a repair, like a teeth falls out or something, you at least have the shade and the shape that you can go back and find which tooth is supposed to be in there. Okay? I'll leave this for you guys to read on your own time. As long as with this, a lot of these 10 major landmarks we've already delineated and marked on our cast, so we should be pretty much familiar with every single one of these. These all help and aid us in setting teeth. So I'm going to quickly just run through the maxillary 3 teeth, so central, lateral, and canine. The central is going to be centered, the contact will be centered at the midline, and there will be a slight distal inclination. They will not be straight up and down. And the reason why is because the zenith of our tooth is not in the middle, in the mesial-distal mid, right? It's slightly pushed off to the side. So that's the reason why we slightly distally cant or incline our centrals. The incisal edge should be hitting the edge of your wax rim in a superior-inferior position. And there's a square metal, it's called a trubite, and that helps you determine what is the occlusal plane. So as you're setting teeth, you're going to be losing more and more wax and be replacing them with teeth. All of those teeth should be in the correct relationship to your trubite ruler, your trubite plane. So centrals are going to be touching the plane. Your laterals will also have a slight distal inclination, but they will be raised up by 0.5 to 1 millimeter. The next one is the canines, and this is always the toughest. They add the most amount of character to a smile. I think of it as the cornerstone of an arch. So the front teeth, when you have protrusive movements, they will be only in the anterior-posterior kind of plane. Posteriors are kind of up and down and therefore chewing and function. The canines kind of have the blended function of both, and they have the special canine guidance that we're trying to gain in setting up teeth. There's 2 main planes that I want you to look at it in. First is from the facial. So when you're looking at it from the facial, you should be able to see a incisal edge that is in line with your cervical neck, and then it should be also slightly distally inclined as well. The cusp tip of the canine will be at level with our maxillary central, so it'll be touching the trubite plane. And then another way to confirm that you set it up correctly is a toeing in effect. So that's when the cuspal tip is slightly pushed in more. If you have a cuspid that's kind of flared outwards, it gives you that vampire kind of appearance, and it's quite unaesthetic. So unless the patient is requiring that you do a teeth setup like this, you should be avoiding it as much as possible. To confirm that you've done your canines correctly, view it from the facial, and you should not be able to see the distal plane of the cusp, of the distal buccal plane of your cusp. Does that make sense? You should only be able to see your facial plane. Okay? Or sorry, your mesial plane of the facial. There's similar slides like these for the lowers. I don't think we're actually going to get to the lowers today, so let's just start with the uppers. Okay? If you're ready to set teeth, come up here. Same thing as how we checked out the articulator box. You're going to check out teeth. They are yours to hold on to, and here's the catcher. If you lose a tooth, you do not get another one. Do not lose these teeth, okay? In the past, people have lost them. You know, you're adjusting them, they just fly and they disappear. Try not to do that, okay? Any questions? Alrighty, let's line up on this side, and I'll check out the teeth for you guys.